Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes. With your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she spent her career helping clinicians and care teams optimize patient outcomes. What if health literacy wasn't about reading levels or pamphlets, but about trust, communication, and human connection? In this episode of the Exam Room podcast, Dr. Winsor sits down with Dr. Catina O'Leary, President and CEO of Health Literacy Media, to challenge common misconceptions about health literacy and explore how it's really about building relationships between providers and patients. Dr. O'Leary shares practical, actionable steps health centers can take to improve understanding and engagement, from using teach-back and chunking methods to creating materials that patients can actually use. Together, they talk about how to rebuild trust, humanize the exam room, and make communication the most powerful tool in care delivery. We thoroughly enjoyed this conversation, and I'm sure you will too. Let's get into it.
Do you think there's people out there, maybe this is a silly question, that when they hear health literacy, they think it just has to do with like reading level or, comprehension level of, reading a brochure or some sort of sheet that has some information on it?
I hear that all the time. So when I say health literacy, the first thing is everybody thinks it's a patient problem. So this idea that if patients were smarter, it would all be cool. And, I have to remind people that famous people in health literacy remind us it's a state, not a trait. So in our worst moments, we all have poor health literacy. So if you think about when you had a fever with, COVID or any of those things, you weren't thinking well either, because it's hard, when we're really, really sick. But the other thing I hear over and over again is, oh gosh, if we just get this to a sixth grade reading level, it'll be fine. I can get anything to a sixth grade reading level. It doesn't mean it makes sense, and it doesn't mean it's helpful. Reading level is not health literacy. It's not about reading level. And it's lazy to minimize and sort of reduce everything to reading level. It's embarrassing. We're better than that.
What would you prefer people think when they hear health literacy?
If I were in charge of the world and people heard health literacy, I would love it if people would think health literacy is a set of tools to improve communication, to achieve an understanding between us, to help people make choices that are the best for them, an informed set of choices toward health, right? If you can understand and make the best choice for yourself in a complex situation, because we've created a system that works, policies, materials, messages, programs that support you doing so. That would be phenomenal. And we can do that. We have the tools to do that. It doesn't cost anything more, really. We waste more money than it costs.
Yeah, I wouldn't disagree with that. And previously you mentioned that we really don't have relationships, nor is the system really set up to facilitate those relationships. First, what are your thoughts about that? Second, my other question is, how do you think trust plays a role in health literacy?
Yeah, so I think these things are so interrelated. So, we were talking earlier about sort of how these things go together and, patient satisfaction and why the scores are so bad. And I think these things happen is, the introduction of technology, right? Like patient satisfaction scores got so much worse when we introduced computers everywhere. And we've got screens everywhere. And when you're so busy looking at the screen and typing in and making sure everything gets into the medical record so that we can fill it and process and move fast, we lost the ability to type and see people at the same time. People don't like that. People want to be seen and people want to be heard. You don't feel like people are with you if they don't look at you and see you. And that's just a fact. That's one of the big problems here, right? And so when you ask if the system is set up for the machines. And we've set up the whole exam room around the machines, getting the computer in the right place so we capture so that we can bill. This whole thing is set up around that. And I'm probably going to make everybody mad, but I mean, it's getting worse with the AI. I mean, we're going to make it even worse. I mean, we want to make sure the machines can like listen and hear us and capture and geez Louise. I mean, they can even like create everything for us. I mean, I hear all the time, we don't need your people to like write or create or design or do anything because the machines can do that too. The AI is like the master, and all of us can just sort of go away while the machines do it. And all the while, the people that we serve feel less and less connected to the people that actually they need to feel heard and understood by, and they need to feel actually care for them.
I agree with you 100%. And even, when the provider comes in and I'm sitting there and they're asking me, okay, like what's going on with you? And their face is behind the laptop. I just see this, top of their head like that. That doesn't feel like connection to me. And I understand the healthcare system. I've been around it for more than half my life. But still, that understanding doesn't negate the fact that I want to feel a connection with the person that is caring for my health.
Right. I'm with you. I also understand, and I understand the shortage of providers. We have to have people see people fast. There aren't enough providers. I was looking for a primary care person, and I live in a big metropolitan center, and I couldn't find a provider in my network near me that fit some pretty broad criteria. But I mean, I was looking for a female provider. I mean, that was kind of it, that lived within 20 miles of me in St. Louis metro area. And I couldn't find somebody for 4 months. That's reflective of, shortages, right? So when you don't have people, they have to see people fast. All these things are happening.
Mm-hmm.
So I understand, right? Like I understand why this is a problem and why, we need the computers to like log everything and do things. But the backside is because of that, then, people don't feel connected. In the verbal communication, the sort of person to person part is there's a gap there. So from a health literacy perspective, what I would say is then we're not going to undo that. So what do? That means that, your primary part of the visit may be very heavily geared around charting things in the computer. But when it's not, when the provider has, their hands on you and they're taking your vital signs and they're talking to you about whatever your primary problem is, that part of the visit needs to be really focused, and it needs to be a really sort of connected period. And you really need to think about the health literacy tools, the best communication tools to get the most out of that visit. And the other supportive providers, the nursing team, even the people at the desks, right? Like the people that are making your appointments, like everybody else wrapped around needs to be really sort of zoned in on what are the factors that can support the patient all the way across the visit, because every piece of the visit matters, right? Like every single thing we do matters, and we're not going to change some things. They're necessary because of the way the world exists. So what else do we do to make it better, knowing that some things aren't adjustable?
Yeah, absolutely. And I was going to bring up the point that you just made about it's not just what happens in the exam room. It starts way before that. And, at the front door with the front desk or, whatever you want to say. We've talked a lot about what's not going right. So what can we do? And are there small, little actionable tweaks that we can make that will make a difference for our patients?
Right. So, I mean, I think some of the smallest interventions that we can implement, the tried and true teach back, first of all, is like health literacy 101. We want to make sure that when people are in our visit, that they actually know what it is that we've talked about before they walk away, and that they actually have that and they're able to sort of speak it back in their own words, and they can walk out the door with that information. That if that happens, that's a win, first of all. This is not something that people talk about every day in health literacy, but I think it's a big deal. We don't always tell people to bring people with them to visits, but I would never advise anybody in my family to ever go to a visit alone, ever, 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 ever. And the more vulnerable you are, the more important this is. Taking somebody with you is a big deal. We do always tell people in health literacy to make sure you have your questions ready. I think providers' offices can always do this, but we often train providers to not ask people what their questions are with their hands on the door. So really making time for people to ask their questions in a way that feels like you mean it, because that doesn't often happen, right? Like we provide information to people and we maybe let them teach it back, but we often don't have time or make time for real questions back from people. There are other people in the office other than the physician or the primary provider. So, this is a place where somebody else maybe can answer the question. When you don't have time, maybe somebody else is the one that comes back in, but making sure people have time to ask all of their questions. One of the things that we do at HLM a lot is we talk to providers and other folks about the most frequently asked questions they hear. And we try to put together a list of frequently asked questions at different practices and different health conditions. We do those in plain language, and we try to provide the responses in plain language and clear sort of actionable steps. But we try to do that so people can have handouts and takeaways. We don't advise people walk out of a visit ever without something that they can walk away with. A lot of times people have sort of stepped away from that because they have things in the EHR. That's a big thing now. It's all in the EHR and you can, click on it or do whatever. We audience test most of our materials and we talk to thousands and thousands of people. Across the board, people will tell you that digital is good because they can go back and listen to it and they can share it. They still want everything they can on paper. They want to be able to write on it. They want to be able to show it to their partner, their kids, their grandparents, whatever. And they want to be able to tuck it down in their purse and go back and do whatever. So those FAQs, things you can write on, things that you can put out between you at the visit and sort of mark up. That's a really big deal. Folks have gotten away from that. Again, I mean, it's cheaper. During COVID, because of the germ kind of thing, everybody got rid of everything that you could write on. And most people haven't gone back to it, but patients really prefer it pretty strongly. So I would advise folks from a health literacy perspective to really think about why we've done that and to whose benefit. I think it's a really good idea to go back to some of that, particularly in older adult populations. And by older adults, I mean mid-40s and up. That's a big deal. When patients ask if they can record things, like on cell phones and stuff like that, a lot of providers will say no. I think we should rethink that. If people need to be able to go back and listen, there's a good reason for that. And so letting people to be able to go back and hear what was said or play it back to somebody is a big deal. Other things that are really helpful for health literacy that don't happen a lot for folks who don't speak English as a first language, we're required by law to make sure that somebody is there to be able to translate for them or interpret. It many times doesn't happen because lots of facilities don't have access or they don't know that they have access to resources to do that. But folks need to figure it out. I mean, if you don't speak English as a first language and your provider does and nobody else is there to help you, that's a problem. Lots of people rely on other people's family members to do that for them. It's not okay. It's not legal to do that. And people don't know that. And, people think it's okay. And people ask why. But, people who love you and have your best interest don't always tell you information exactly as it's provided by a medical provider because they love you, right? So they don't always give you information exactly as it's provided because they love you, and then you can't make information or you can't make the informed decision for yourself because somebody, cares so much that they have sort of tilted the information in the way that they think is best for you. And I'll use the example of, living organ donation, for example. Maybe somebody doesn't think that you should have a transplant because, for religious reasons or something like that, they don't think it's relevant. And so perhaps that would be something that they didn't share, maybe. There are all kinds of things like that that might change what someone shares with someone else based on, beliefs in a family. If you have a translator or interpreter, the information gets shared exactly as it's provided by the medical professional, and it's not filtered through the lens of another family member who would love you so much and have a shared history that maybe they change the information based on what they think they know.
Yeah, that's such a good point. And, as I was hearing you kind of list off all of these different things that patients can do to help themselves or that healthcare providers can facilitate so that the patient can be more successful.
it got me thinking about, in teaching, we talk about the learning styles. So it used to be like, oh, find your learning style. Okay, you're a kinesthetic learner. Well, you need to learn by hands-on things. You're a reader, you're a listener, you're, whatever the case may be. And then research kind of shifted to the more learning styles you can incorporate in a learning experience, the more likely it is to stick in your brain. And so as you were mentioning, something they can listen to, something they can read, something they can ride on, all of those things are going to increase the chance that they, one, have an understanding, two, maybe hopefully have some sort of behavior change elicited from the conversation that, they have with the provider or whatnot, but maybe even having a health journal, that you just dedicate or take with you. For me, I use my notes like in my phone because that's easy. Jotting down what the provider says is not as easy using that modality, but at least I have it with me all the time. And if I know I have an appointment coming up, I can just jot it down in my notes so that it is there with me when I go, and I'm not having to wait till I can get somewhere to write it down. So all of those pieces, I think, kind of come together to increase the success of our patient.
Absolutely. And, it's so easy, like getting back to things like the FAQs and things. We do a lot of materials. We did a set of screening materials for lung cancer folks that were doing lung cancer screenings. And so there were lots of FAQs and things like that, reasons for screening. But anytime you have something like that, you have extra space often. So it's easy to use those extra spaces on a material for like notes or questions, right? So when you create those things and you bring back paper for any purpose, things that you want people to know when they leave a visit, there's a space for notes. You often also have to write down the next visit. You give people an appointment card almost always. It could be that your appointment is on the paper with all this other stuff that's useful, including where you're going. Like, why do we waste the piece of paper on heavy cardstock with only the appointment and only the address when you could actually use one piece of paper that actually has some useful information about what they need to know and then include this stuff? Like, there are ways to still not make it cost anything and do what we need to do and, still be stuck with one piece of paper when you walk away.
Mm-hmm.
We need to think back. I mean, everything doesn't have to be new and fancy, right? I mean, sometimes old things worked for a reason. We know that when, we write things down, we remember it more than when we type it on our computer. We know that. I mean, it's very well documented. That's what works. I mean, that's, what they're telling all the cool kids in college right now, right? There's a difference between when we write things down and when we type them. It's a basic learning strategy. And so it's important, and it's in a health visit. We need to get people in the practice of writing it if we want them to do it. And we want them to do it because it makes them well. It makes them come back less. We need them to come back for the right reasons. We don't need them to come back because they didn't get it the first time. And if they're coming back because they didn't get it the first time, that means they're taking somebody else's spot. And we don't have extra spots for people to just come back because we didn't do it well enough, right? So we need to figure out how to help people get it the first time and only come back because they're coming for the next thing. We need to do it well. We need to do our jobs well. We don't need to waste their money. We don't need to waste anybody's time. And we can do a better job.
So we talked about the teach back method and how that can be used. In a previous conversation that you and I had, you mentioned chunking. Do you want to talk a little bit about like how they might be able to use that?
Sure. So, chunking is just this idea of putting together like pieces of information into chunks so that people get little bits of information together and it's chunked together so that it fits. And how this goes together in a medical situation is very frequently you get so much information in an appointment and it just sort of all comes at you at one time and it's all over the place. And it's hard to remember that. But if it's chunked, you'll get all the information about like your blood pressure all chunked together in one spot. And so they'll tell you, this is the information about your blood pressure and you need to remember these two things. And now this is the information about your cholesterol. And let me tell you these two things. And you get these little chunks of information so that you have it all together and it's just one or two things in little chunks that are put together in order. instead of everything that just sort of flies together in one place. And we go out of our way when we're chunking information to really identify the chunk and give you the pieces in one spot. Mm-hmm. And again, all of this is really important. And when we're creating a material, we think about chunking and we make sure it's just one or two things. We can't hold more than a couple pieces of information at one time. So, we don't want to give people like 5 or 6 bullets about a thing. They just don't remember. So we have to make sure it's just one or two things. We're really specific and they're important things. It's need to know. It's not nice to know information. So we often talk about what's the difference between need to know and nice to know. And what we say to folks is need to know is something that is necessary to actually do something. So like the actual behavior. And nice to know is like background. 90% of people in the country have a problem with this, that, or the other. But need to know is you need to take this medicine when you get up with food. That's a need to know versus a nice to know. So those are the chunks of information that are necessary. Like you're going to take this medicine for your cholesterol at morning and night, and you need it with food. Little chunk of information, you get it once. And again, all of that needs to go together in a written form, not just verbal, and they need it when they walk away in that chunk, separate pieces. And they should be able to speak it back to you. All of that together, teach it back.
Yeah, so how does the handoff kind of fit in with that? The teach back and the chunking, where does the handoff come in?
I think, where I see it work really well is when often the provider, the primary physician, is in the room doing a lot of the diagnostics and they're doing a lot of the, checks and figuring things out and, they're ready to go. And then they sort of pass off to a nurse or, physician assistant or nurse practitioner or whoever that is. And they sort of start to go through the next steps. And that works out really well. I mean, people then feel like the trust has been passed off and they can feel comfortable that the provider in front of them is authorized by the physician to do whatever they say. It's really funny. We ask this question a lot in focus groups, but people trust their physician implicitly, their primary care doctor. Specialists are a little scary to them, but their primary care doctor is the person they trust most across the board. Mm-hmm. But to them, that often means anybody in that office, right? So even the person at the front desk, when they call and tell them to do something, they infer that that's their primary doctor. So the physician is the physician's office and everybody in it. So the handoff is okay if like the person in the office has heard the doctor say something and they describe it. It's okay then at that point if that person goes through the steps and goes through the instructions and then does the teach back, right? So there's no reason that the doctor actually has to be the one to do the teach back. So that idea that the teach back can't work because the doctor doesn't have more than 8 minutes or 10 minutes or 12 minutes or whatever it is, that doesn't matter as long as someone else in the clinical environment can step in and, have heard enough to know what the instructions are and then can go through the process with them.
That's one of the things that we're focusing on is VB Care is developing their own patient education program. Mm-hmm. And, that's our hypothesis as well, is that we want it to also not only raise health literacy or understanding of their chronic condition or whatever they're learning about, but to hopefully have that additional motivator that your provider is the one that's, really advocating for that and will kind of be that common thread throughout the program. Mm-hmm. And from what I'm hearing you say, like that's definitely a thing.
We have talked to thousands of people. We work really hard to test everything we create, or at least everything in a topic area. So we may not create, or we may not test every single material we create, but every time we start on a topic area, we create and we test at least some version of the material so we can understand the intended audience, at least enough. So we talk to folks in the intended audience and we make sure that we understand enough about the people who are living with the health condition and all the different sort of subsets of folks. And across the board, we hear that people trust most their physician. And by physician, they mean the doctor and anybody in that office.
Mhm.
Anybody in that office, they presume is the doctor. And you can say doctor, and that means everybody. Even
Yeah.
the person at the front desk that calls them to remind them of the appointment, that is still the doctor's office. And it's really interesting because we put that in material sometimes, and sometimes people at companies are like, but it's not the doctor. And it's like, well, I mean, we can say the doctor's office, or we can say, the receptionist from the doctor's office, or we can say the surgeon, or we can say all those things. But to the person that's reading this, they just mean the doctor.
Yeah.
That's all they mean.
Mhm.
So we can make it harder if you want, but people mean the doctor, and they're comfortable with that. And it really,
Yeah.
it's a trust thing, and they don't care about all of these other derivatives that we've created or whatever. I mean, these are things that we've created that mean something, in our systems, but to them, it's like, I trust this person in this system, and this person is the person that I've selected, and they have promised me that they're going to take care of me, and they have chosen all of these people to help them take care of me, and I trust that.
Yeah.
And until something goes wrong and I'm saying I don't want that person to care for me anymore, then all of these people that work with them in that place are sort of approved for my care. It's interesting.
It really is interesting.
Thank you for joining us in the exam room, where we examine the vital signs of value-based care and diagnose what's shaping the future of healthcare. We hope this conversation was as insightful as your last checkup. A big thank you to our guests for sharing their expertise and prescribing actionable ideas. Stay tuned for more episodes as we probe the topics that matter most in value-based care. Until next time, take care, and thanks for listening to The Exam Room.